the first to publish something, a new finding. In this case, everyone had the same mission. Let's end the pandemic as quickly as possible. So that actually gave me the ringside view to say that if the world decides that there's a... Speaking to scientists and doctors from around the world, we used to have regular conferences with them. Some of them would point out that the policies that WHO makes is for the world, but sometimes they are not applicable everywhere. Biomedical part is sometimes easier to handle than the social, but in India it was quite a change for everyone to go around wearing a mask. It was like again stigmatizing in some way. So she would often challenge policymakers and say that your policy is a little bit out of touch with the reality of working women and what they need. And so just giving them a basket of food, not just for the patient but also for the family members, not only improve the patient outcomes but reduce the TB amongst the family members by 50%. Nutrition itself is a vaccine, because for TB and HIV and diseases.
Good evening, everyone. On behalf of Super Chennai, I extend a very, very warm welcome to each and every one of you to the next edition of Arattai. This evening's Arattai is truly graced by someone who has quietly shaped how India and the world thinks about health, science and justice. Dr. Soumya Swaminathan, thank you so much, ma'am, for agreeing to be here. We're really, really looking forward to this conversation. Please allow me just a moment to introduce you. Dr. Soumya Swaminathan is a pediatrician, one of the foremost global voices in tuberculosis, HIV and public health, having served as chief scientist at the World Health Organization and earlier as Director General of the Indian Council of Medical Research, where she really pushed hard to make science central to India's health policy. Her roots are deeply embedded in this city and in Tamil Nadu's legacy of public-minded science. As chairperson of the MS Swaminathan Research Foundation, she carries forward the work of her father, legendary agricultural scientist MS Swaminathan, and her mother, educationist Meena Swaminathan, building really bridges between agriculture, nutrition, climate resilience, and community health. In this conversation, we really attempt to explore the idea of this intersection between science and public systems, between global leadership and local responsibility, between what happens in laboratories and what really happens in our lanes and our homes. Ladies and gentlemen, please put your hands together and welcome on stage Dr. Soumya Swaminathan. Thank you so much.
Thank you very much.
So I'm going to, dive straight in and ask you a question actually about the years of the pandemic.
Yes.
So across the years of the pandemic, we saw you not only as a scientist analyzing data, but also as someone deeply vocal about equity, ethics, and the human cost of the COVID-19 pandemic. I'm really curious to understand, how do you hold these two identities together of being a rigorous scientist, but also as someone with a large human heart? And I'm curious to understand, what have you learned about bringing compassion into spaces that are largely driven by, evidence and policy?
Yeah, thank you. I think it's a good question. Actually, I've not thought about it, but I think it must have been shaped by some, early experiences and the influences that I had growing up. The fact that on the one hand, rigorous science, data and evidence is very important in order to move policy, or to change practice. But on the other hand, if you lose sight of the human face of those changes, sometimes you're either making inadvertent, mistakes. There may be things which are happening which you did not anticipate, which are not good. And on the other hand, your policies could end up benefiting a section of the population alone. And that's something similar happened during COVID, where we saw that vaccines were developed with tremendous speed, that there was fantastic cooperation and collaboration between scientists all over the world. I must say, I've never witnessed anything like that. where people were working day and night to advance understanding of COVID, and they were sharing absolutely openly, uninhibitedly, without even thinking about, their publications. And normally scientists like to hang on to their data because they want to be the first to publish something, a new finding. In this case, everyone had the same mission. Let's end the pandemic as quickly as possible. So that actually gave me the ringside view to say that if the world decides that there's a problem to be solved and the world scientists come together, and this was very interdisciplinary work. So we had aerosol engineers working on how the virus is spreading. We had the immunologists, we had the virologists, we had the doctors who were looking at patients in the clinic. We had the behavioral and public health people. We also had social scientists who were looking at the behavioral aspects and which interventions were working. So tremendous increase in, I think it was like literally thousands of papers a day at one point being published. But at the same time, we saw the inequities in a couple of ways. One was the vaccines itself, which did not become available to many African countries till very late in 2021, when the rest of the world was already well vaccinated. And the other inequity we saw was that the poorest in every country suffered the most. They were the first to lose jobs. They were the first, to be having to migrate back to their homes. And in every way, they became more food insecure. The children missed school in some countries like India for up to 2 years. But again, the high-income countries did not close schools. They closed only for a few weeks. But the majority of developing countries closed schools indefinitely. Children missed out on education, also on their school meals. And I think that generation has been impacted by long-term impacts, I think, are there. So, even early in the pandemic, I think these things became obvious. And also when we were speaking to scientists and doctors from around the world, we used to have regular conferences with them. Some of them would point out that the policies that WHO makes is for the world, but sometimes they are not applicable everywhere. And this is why countries really need to take the recommendations of WHO, but then adapt them to their own local, because clearly some of them would not be the right ones for a particular place.
Dr. Swaminathan, you use this word interdisciplinary.
Yes.
And in today's context, I worked at CREDAI University, and, interdisciplinary is a very common word. We're using it very, very, it's a very trending word, so to speak. But in your case, interdisciplinary has sort of been part of your approach for a while without actually being labeled interdisciplinary. Could you tell me a little bit about why interdisciplinary is really crucial in the world that we live in?
See, I can give you an example from my own work, which was on tuberculosis and on HIV and TB, because when I started working in the early 90s in the Tuberculosis Research Center in Chetpet, HIV, was already there in India. Of course, it was extremely stigmatized and extremely hidden. But very soon, it got to the point where the hospitals were getting flooded. At that time, Tambaram Sanatorium was one of the few hospitals in South India that would accept HIV patients. So literally that whole sanatorium became an HIV sanatorium, really. But even before that, when I had started working on TB, I realized that some of these diseases, though we call them infectious diseases and we know they're caused by a bacterium or a virus, the biomedical part is sometimes easier to handle than the social parts of the disease. For example, both in TB and HIV, you have a lot of stigma. Families do not like to at all acknowledge that they have anyone with that disease. And in the olden days, TB was considered genetic. The girl would not get married if somebody had TB in the family, and so on. I think any disease which has a high fatality, there's a strong stigma. And this is why in COVID also we saw the stigma, right? Landlords were telling doctors and nurses to vacate homes because they were so scared that they would bring the virus back. So, and then we saw that there were so many things that were associated, like poverty being a very, it's a risk factor for TB, poverty and undernutrition and poor housing. Similarly, for HIV, again, it was associated with with both sex work, but also obviously with people's behavior. And so unless you can change behavior, um, during COVID, we saw that mask wearing came very easily to some populations, like in East Asia. If you go to Japan or Korea, people wear masks all the time. There's nothing unusual about it. But in India, it was quite a change for everyone to go around wearing a mask. It was like, again, stigmatizing in some way. So I realized early on that when you are dealing with diseases like TB and HIV, that just being a medical doctor and prescribing medicines alone is not going to be sufficient. Every day we would hear stories from patients about problems they had at home, the fact that they couldn't go to work, that children had to drop out of school, that sometimes the family would ask them to leave, and especially if the man died, for example, in an HIV infected family, the in-laws would often blame the wife, as usual, for having brought. It was very clear that it was the man who had acquired the infection and passed it to his wife and sometimes the children. But the family response was always to blame it on the woman and to ask her to leave the home. And, she was denied all her rights, her inheritance, and so on. So I saw many, many children being orphaned, and no one wanted to take care of them, so they would end up in an orphanage. And this was before we had antiretroviral treatment. So what we could do was to treat their other infections like TB, to keep them comfortable, to try to give them as good a quality of life as possible, to maintain nutrition, and to support the family with all these other things that they needed. They needed help with legal services. They needed help with children's admission, sometimes with housing or finding a job. The widows would need, to sustain themselves later. And then, of course, there was a whole group of gay people and transgender people who were even further stigmatized. And so to reach them and to get them to accept HIV prevention was, and of course it's a taboo, right? We don't talk about sexual behaviors in India. So I think HIV kind of broke that taboo. There was mass campaigns on the use of condoms and so on. That is when I realized that you need this interdisciplinary approach. And we had a group of social scientists in the institute, and they formed very much a part of our research team, and also, took care of these other needs of people. We, of course, had also very strong backup from our labs, because without the lab data and the investigations, we could not judge where patients were on their course, particularly in HIV. So then, of course, we saw transformation after 2004 when the government introduced antiretroviral therapy. It became a very treatable infection, and then people can now live much, much longer. In fact, almost a normal lifespan, as long as they're on treatment. But other problems came of side effects. The early drugs had a lot of side effects. And in fact, the side effect was such that by looking at a person, you could tell that they were HIV on treatment, because they would lose all the fat on the face. It was a very typical look which would come. So that created its own issues. And then the dealing with the children as they grew up and came to know, or they wondered about HIV, they wondered what happened to the parents, to their father, and no one would tell them anything, because again, we're not used to talking to children about these things. And I remember one little girl who was about 14 then, her mother was a patient, and so was she. And then mother came one day and said, the girl is saying that we should both commit suicide. And I said, why? Because she said, she's saying this is a hopeless life. Why should we both be alive? Because we're never going to live normally in this society. So it's better we end our life. And then I realized that this was an issue that we had been blind to, that with children and adolescents, we were really not picking up and talking about these issues. So then we started the counseling program and so on, but it is quite difficult.
I was just going to ask you a little bit about, we walked into this space. It's really such an oasis of calm. I'm curious to know, what are some of the memories that that often come to you when you walk into this space?
Yeah, this place was conceptualized and designed, and literally brick by brick, my father and my mother, both of them, had conceived of the space, and the architect actually is a cousin of mine, Venkat Ayyadurai. He's a very well-known architect. At that time, he was a young man and trained, with Jeffrey Bawa and so on. So the whole idea was that firstly, that this should be an open and welcoming place where everyone is welcome to come, whether you're a farmer or a student or a scientist. And so it should have that feel. The second is that it should be sustainable. So it was designed with natural light, ventilation, and we had solar on top, on the roof right from the very beginning. And then if you see the central courtyard, it's actually designed to reflect the 5 agroecological zones that are described in Sangam literature, some 2000 years ago. So the garden is designed like that, to remember that we have those different agroecological zones, and therefore we also need to think about that when we are doing our research. So this building came up in 92 or so, 91, 92. And at that time, I had my own career and so on. I was peripherally involved with the foundation, and my parents were very active. But my children were small then. So we used to come here for all get-togethers. So my mother was very particular that we have to have staff get-togethers and picnics and everything regularly. Christmas party, Diwali party, everything, all celebrations. And so I used to bring the children here, and they would enjoy being here. And of course, on my father's birthday, there was always a big cake cutting. All the students would come from all over India. So it was a very joyous occasion.
Must be nostalgic to walk in each and every time.
Absolutely,
Yeah.
yes.
I want to go back a little bit and ask you about, you grew up in a home where science and social responsibility were probably everyday conversations, dinner table conversations. How did the city, Chennai, and you said you grew up in Delhi actually, and the family environment really shape your earliest ideas of what a life in science could be?
Yeah, as you said, I grew up in Delhi, moved to Chennai in 1991 actually, so lived here since then. But the early years were growing up on a agricultural research campus, the IARI campus, or what's called Pusa Institute in Delhi. So large campus with many, many, many acres of fields where the experiments are done by the scientists, and then many buildings which are laboratories and research buildings, hostels, students from all over the world actually come to study there. So big international students hostel, and so full of scientists, students, etc. And our home was always full of. So even when my father worked very long hours, but even when he came home in the evening, there were always a few students waiting to discuss their thesis with him. And so while they were waiting, they would play with us in the garden. In fact, they were not allowed to go in unless they played with us. And then they could go in to discuss their work. And so we saw what a life in science actually looked like firsthand. And we also met many scientists, national and international, who were visiting the institute and who would come home. So I think I realized very early on that the work it takes over your life. It's constantly there. You're all the time thinking about it and working on it. And so my father was very busy, traveled a lot, and so on. My mother was a preschool educationist, and so she set up the first creche and preschool in the institute to cater to the children of all employees, whether they were class 4 employees or staff or students. Their children could be in the preschool, and she used a lot of experimental methods and developed style of teaching through play, because these were very young children. And she was one of the first people to recognize that the first 1,000 days of life are important. And she was part of the team that actually conceptualized the ICDS program, which even till today it's called the Poshan Abhiyan, but basically it's the ICDS, which was conceptualized in the early 70s to both cognitively stimulate and to make sure that nutritionally the young child is adequately fed. And she was also champion and a feminist. I mean, she was an activist and a feminist, I would say. And she fought for women's rights. She fought for maternity leave. She fought for breastfeeding facilities. And she was, that way ahead of her time, I would say. So she was more like a rights-based kind of a person who was also very grounded in realities and in data, and spoke always from experience of having worked with working women from lower income groups and the challenges they faced. So she would often challenge policymakers and say that your policy is a little bit out of touch with the reality of working women and what they need. So to say that you should breastfeed your child for 6 months is theoretically good. We know it should be done. How do you enable it to happen? How do you support a woman who has to do multiple things to also be able to breastfeed her child for 6 months?
You spoke about your parents, ma'am. I just want to ask you to tell me a little bit about what is the one quality about your father that you really, really admire, and one quality of your mother that you truly value, just because you just spoke so fondly of them right now.
So my father, I think the quality I admire is that nobody's ever seen him get angry, ever. Whether it's co-workers or whether it's family members or we at home, never ever lost his temper. He was so patient and willing to listen, to all points of view. Even if people were directly attacking him, he wouldn't respond with anger at all. So that was one quality which is very, very hard, I think, but he had that, from day one till the end. And my mother's quality that I admire was her ability to speak up, even when it was very difficult, unpopular, and uncomfortable. She would speak it and she would lay out what was on her mind, and maybe sometimes it was things which others could not have said. In the process, she made enemies, yeah, because she was not at all scared to confront people.
Dr. Swaminathan, you returned to India in the early 1990s and joined the National Institute for Research in Tuberculosis in Chennai. Much of your work really involved going into communities and homes. I know that there are a lot of students here as well. I want you to tell us a little bit about what it is to really roll up your sleeves and go into the field, and why field work is so crucial.
Yeah, I think especially for the students, whether you're medical students or other kinds of students, most of our teaching happens in classrooms, and if you're a medical student, you're in the clinic or the hospital. We never get to know the other side of the patient, right? We get to know them by the disease for which they've come, and we focus on that and we try and make them better. The good thing about the NIRT or the TB Research Institute was that because it's a research institute, and we needed to keep people under follow-up for very long, because whether it was a clinical trial or some other kind of a study, you require that long follow-up. So TB as such is a disease which requires a long treatment, and then we had to follow them sometimes for 3 years, 5 years, sometimes 15 years. We've done studies which we followed for 15 years. This meant that you had to get to know the patient and their family extremely well. So we had a system where if a person had an appointment and they didn't come on that day, the nurse would go and visit. And if he or she, generally men, I think more often get TB than women, but if the patient didn't come, then the next day a senior nurse would go. And on the third day, the doctor had to go. So as a result, what happened is that I got to see all the places in Chennai where these TB patients came from, and mostly it was from the low-income places, housing boards, hutments on the banks of the Kuam and things like that. So that actually gave an insight into what is the life of this person like. We are only seeing them in the clinic for 10 minutes or 15 minutes or 20 minutes. And we give a lot of advice, do this, do that, stop smoking, stop drinking, eat well. Why are you not taking your medicines? Scold the person. And then you go to that person's house. He or she is living in one hut on the edge of the river, and rains have come, things have got washed away. They may or may not have food. Of course, alcoholism is and was a big issue, continues to be a big issue for the men especially. Could not give up drinking, even though, and because we had scared them that if you drink and take your tablets, you will start vomiting blood, and doctors would scare them thinking they'll stay off alcohol, but instead they would stay off the drugs if they could not resist. going back to the alcohol, tobacco. Children have to be fed. Many of them are daily wage workers. There was no income, no food. And that kind of opened my eyes. I said, okay, as a doctor, I'm sitting here and having a very superior and condescending approach to this person and giving a lot of advice. What if I had been in that person's position? Would I behave differently? Or would I also treat my treatment as a secondary thing? My first thing is to survival and to keep my family fed. My treatment, once I'm feeling a little better, I may skip a few days of treatment. So it gives you insights and perspective, exactly. And when you go home, then people also talk to you more freely, but the kind of hospitality that even the poorest people have is really amazing in India. I've seen everywhere, anywhere you go, the poorest family will invite you in for a cup of tea, and so on. So it grounds you, but it also gives you insights into where the policies need to shift. And all my work on nutrition and TB and nutrition and HIV basically came from seeing what the situation is on the ground. And in Chennai, still we are relatively better off. You go to remote villages of Bihar, Odisha, Jharkhand. Literally, there's no food in the house once the primary earner is sick. And so this is why then the national program also added a nutrition component to the TB and the HIV program, recognizing, and we scientifically proved that giving nutrition is not just a nice thing which we're doing because we're feeling sorry. It improves them to get better faster, it reduces the death rate, and it prevents others in the family from getting TB. So there's a very famous trial called the Rations trial that was done in Jharkhand. It's funded by the ICMR. Showed that in tribal families in Jharkhand, where the mean BMI of patients was 16. Can you imagine? Even healthy people have a BMI there of 16 and 17. So when you get TB, then your BMI goes down to 11 and 12 and 8 and things which are not compatible with life. But these people are living with such BMIs. And so just giving them a basket of food, not just for the patient, but also for the family members, not only improve the patient outcomes, but reduce the TB amongst the family members by 50%. So better than any vaccine. And so we started saying nutrition itself is a vaccine, because for TB and HIV and diseases, we don't have a vaccine. So nutrition can actually serve as a very good vaccine. So that became part of policy, but it took a very long time to convince the government that this was an important thing to do, because health ministry is not in charge of nutrition, right? So health ministry is in charge of diagnostics and drugs and vaccines. He said, well, it's not in our budget, we can't do it. So where do you go then? So someone else has to do it. But, I think India was early on to recognize, and this trial done in Jharkhand is now globally quoted. It is in WHO guidelines. All countries around the world now change their nutrition guidelines based on the work done in India.
I want to ask you a little bit about, you've worked at the highest levels of global health. Just want to put the spotlight a little bit on Chennai and ask you, in what ways has your Chennai experience, even though you did not spend your early years here, continued to travel with you into all these global rooms, so to speak?
So I spent a lot of time in Tamil Nadu when I was young, because every summer holidays we would come to Kumbakonam via Chennai.
Okay.
So we would take the Grand Trunk Express, land in Chennai, and spend a couple of days here with my peripa, and then go. My grandmother lived in Kumbakonam, and so summer holidays were spent. My grandfather took us to temples. We had cows at home, so we had very happy holidays, carefree, and we saw all the temples in Tanjore district when we were young, and we were only bought khadi clothes and all that because my grandparents were Gandhians and so on. So I think that was such a contrast from our life in Delhi, that it was a conservative, traditional household, and we had rules and regulations, particularly for girls. So we learned that you have to adapt. And if you are in a situation where you need to follow a different set of rules, you do it, to keep the elders happy. So had been exposed to quite a lot of different cultures within India itself, because we had traveled with my parents. So when I went for the first time to WHO was 2007 to 9, actually did a 2-year stint, 2009 to 11 it was. where I was working on neglected tropical diseases. So I got to travel in Africa a little bit and South America, where again, in Africa, of course, the deprivations you see are even more, much more than you see in India. The lack of facilities, the lack of any kind of resources. So I think those exposures and plus the grounding in childhood gave me the breadth, I think, of experience that came in very useful for my stint as chief scientist at WHO, because people who've had a very narrow exposure in one country, in one hospital or one setting, cannot imagine the diversity that exists and the need to adapt policy. And also, I was very sensitive to the fact that our committees in WHO needed to be very broad-based, and we started making, and Dr. Tedros, who came from Ethiopia, obviously was also very sensitive to this. And so we kind of really went out of our way to get experts from all over the world, geographically and gender balanced, so that we got those insights. And it really helped, because we had people who would speak up and say that, your guideline is not going to suit our country for this particular reason. We also had patient advocates, survivors of TB and HIV on our committees. And they were sometimes the most vocal people, and they said, what are you talking about? You don't know what it is like to have TB. I've suffered from TB. I know. I've had the side effects. Your guidelines need to change. And this is why I think involving the end user, the civil society, patient groups in our policy making, particularly for health, is very, very important, because it is impossible to know what they go through unless you've been through it yourself. And the next best thing to having gone through it yourself is to listen to someone who's gone through it. And whether it's, if you talk to people who've gone to a government hospital or a primary health center, they will tell you exactly what their experience is and where the pain points are, which you can then fix. So I hope that Tamil Nadu government is one of the first to set up the People's Health Assembly. And I hope it continues, because I've seen it in Thailand and how effective it is. The People's Health Assembly allows people, starting from the village and panchayat level, then district level, then state level. And there they do it at the national level in Thailand, where the health minister actually chairs the meeting, allowing ordinary people to talk about the health system, what their experiences are, and how it can be improved. And I think it's only with that kind of feedback and participation of the community that our programs will be successful. In a way, maybe it's good, and we have known for a long time. A lot of people say, oh, you left a global thing and you came and were working with communities. Gives you a lot of satisfaction. We shouldn't just be using AI for the sake of AI. Obviously, it has to improve health outcomes, and it also needs to be tested. The digital should not overburden. It has to reduce the burden on the healthcare provider. Chennai is thinking about urban primary healthcare. That will reduce out of pocket.